Okay.
Okay.
I forgot how old she is actually. What did I say? How old is she?
Okay, you should be able to see my screen. Can you see the case there, Naomi?
Yep.
Okay, let's put you into slideshow mode. Okay. So Naomi, do you want to
talk about it? Yeah, sure. Okay, so she's a 13-year-old girl.
Yep.
And her main concern is the canine sticking out.
Yep.
I would describe her as mesofacial.
Let's.
If I remember correctly. Hang on. Where's the Ceph?
Okay. Well, we'll just go by the facial photos.
She's got a really nice smile. She's a little bit full in her face profile. I mean, if you look at the lips, but she's got a lot of growth, so I'll take that into account. She's convex, retrognathic mandible, competent lips, full, thick lips. So
yep.
You want that fullness. You don't want
what nationality is she?
Fijian. I think her father's her mum's Caucasian, but her dad's either Fijian or Sri Lankan.
Yeah. So, because you've got to look at the facial profile based on the ethnicity of the person. You know, if that was an Asian patient, that would be a very normal, average profile.
Yeah, I agree.
And being Fijian, probably the same. The same.
Yeah. So you don't want to attract. You want to, the upper midline is to the left because of that canine, but the lower is a bit to the right.
Yep.
Her bites.
Well, we'll do.
Later. Okay. Well, that's it. She's mesofacial, full profile, class 2.
Okay.
Skeletal. Her AMD was like 7, I think it was.
Yep. Okay.
Wits was about 2, so Wits wasn't too bad.
Okay. Well, we'll get into the Ceph analysis in a second. Let's have a look at the. Let's have.
Okay. So skeletally, she's got a locked-in class 1.
Yeah.
On her molars, so. But the lower incisors are way out. They're like 112. So that was my issue, and there was crowding. So.
Okay, so she's got she's got some moderate crowding.
Yeah.
A high upper left canine with blocked out, midline discrepancy. Yeah, which really, in all honesty, nobody's going to care.
Oh, the midline discrepancy, I'm not concerned about.
Yeah.
My biggest thing is when I look at whether to extract or not is the position of the lower incisors, and also obviously the amount of crowding, but the profile. So I was like in a bit of a conundrum what to do, because I thought, well, she didn't have any crowding that much on the lower arch. I probably wouldn't extract, but she's got crowding. So, and there's really too much to procline those incisors any further, I think. So my gut feeling was to extract, but I was going to go the 5s rather than the 4s.
Okay, well,
but then I don't know. That was my idea.
Okay, so let's just look at her set for a second, okay?
Yeah.
Okay, so she's probably mesofacial. I wouldn't call her brachyfacial here. So she's mesofacial.
Can I just ask, is that Ceph taken well? Is that pretty?
Yeah, that Ceph's not too bad. She's probably looking up a little bit, but it's actually pretty good.
All right.
Yeah, it's actually I'm going to say very good. So it's actually a very nice Ceph because you can actually see the stuff posterior, apart from her earrings, which is
sorry, I forgot to take them out. My staff sometimes forget to ask.
So do you have your own Ceph machine? Do you?
Yeah, we've got Ceph, CB, CT.
Okay, now that's a very nice. What Ceph machine do you have?
Hyperion from Italian, Italy.
Yeah, no, it's a very nice picture. Okay, so the APG is...
And that's ours too as well. So.
Yep. Yeah. Okay, so here we are. We've got some mild lower crowding. Okay, and your concern, and she is a class 1. So she's a class 1 with her midlines being fairly significant off, the lower midline being fairly significantly off. So really, the problem is this the buccal shots are not taken totally perpendicular.
Yeah, I'm looking at
Sorry, you can't.
models, and they're pretty class 1.
So
the bolus is lucked in.
Yeah, I would actually say, I reckon if you took it perfectly straight on, I reckon that canine's and mildly class 3.
Yeah.
Okay. If you do it, and that would make sense because your lower midline is way off.
Okay. Yeah. Yeah. Okay.
If you moved everything around, you probably end up with a class 1, perfect class 1 canine. So you're probably just a fraction on the class 3 side if you took your photo exactly right. That's what I'm just here. Okay. So, okay.
Extract or not to extract? I think you have to extract. That's my gut feeling. So.
Well, yeah, if you don't want to procline the incisors, I mean, she's got very thick lips. Okay. Okay, so if you go in, her lips.
Or do you try?
Well, you could do, but let's just, it depends on what you're trying to do. Okay, because when you go to a facial profile, could you do with some retraction minimally? Yes. Okay, if you, okay, I mean you're not going to destroy her if you did some retraction, but not a massive amount. Okay. The question is, do you like?
Well, that's why I thought the 5.
Yeah, well, and I would agree with you from that point of view, or, and this is your other interesting part here. Okay, so do you have a Bolton discrepancy?
I was going to extract. Let's have a look. I didn't think so. What? I didn't.
See, I'm gonna
You think the upper laterals are not? Maybe. You think the upper laterals are too wide?
I reckon you probably do have a Bolton discrepancy.
Yeah, that'll be
okay. And I say that because here you're class 1. You've got so much crowding in the lowers.
Yeah, I'll check it out.
Okay, because the other possibility here is to say, okay, most of my crowding is in the lower anterior region. That's where your concern is, correct? Have you got? You don't have much of a concern of getting the upper left canine in.
I don't have any concern with that canine.
Okay, so we've got no concern in getting the.
If I had to, I don't have a problem with her upper ones were 112, but that's okay. She can. It's not bad.
Okay, so the question is, how do we resolve this lower crowding? And you got 2 options. You can either make a difficult case for yourself, okay, which is fine, because probably the ideal treatment plan, because she's class 1 here, right? Okay, or we think she's class 1. You could take out the second premolar teeth. If she's really class 3 on this left hand, on the lower left hand side, if
the lower central.
Well, we'll just go back a stage. If she's really class 3, and you actually want to move her lower midline around significantly, okay, you might take out the 1.525, but on the lower arch you take out the lower left 4 to give you a bit more retraction of that canine, and allow you to move the midline across a bit more, and still take out the lower right 5. So you do it.
And then the uppers, you have to take out uppers.
Yeah. So that's
taking out lowers, you have to take out uppers.
Oh yeah, absolutely. So you take out upper 5s. That's on the basis though. Sorry, you're cutting out, Naomi.
The midline will be an issue. I think because once you open up that space with some coil, the midline will move across anyway.
Well,
so if you put open, it'll move across anyway. So
it will move across, but it's just to do with your anchorage requirements. It's going to be a lot easier if you take out a lower left 4. If that's what you want to correct, okay. But it's not wrong to take out for all 5s. You're just going to have to manage your anchorage better. I think your internet's really poor there, Naomi.
Yeah, I know. Hang on. Let me try and move. Would you take out... Hang on, let me go.
So Sorry?
Can you hear me now?
Yep, that's better.
Would you take out lower 5s, upper 4s?
No.
Because of the class 1, right?
Exactly. If you're taking out lower 5s, upper 4s, that's more of a class 2 situation.
Yeah. Okay, that's what I thought. Okay.
Yeah. But you could take out upper 5s.
Yep.
Lower left 4 and
Yep.
lower right 5.
Yeah, I thought of that too. Okay, well, at least I had my diagnosis correct.
But the other option you've got is to keep it simple and just take out one lower incisor.
Yeah, I know that.
and take out that lower right lateral. And basically then your midline is going to be pretty well on, because you want that midline to be in the middle.
So which one would you take out? The 4?
I would take out the 4 too.
Hang on, but that'll make the midline go over more.
Yep. But what you want is the midline then.
Yeah.
Yeah, once you take
half
the incisor, it should be in the middle of that middle incisor.
The only problem if I did that, Jeff, and I assume if I take out the lower central, are you saying non-extraction on the top?
Yeah, non-extraction on the top.
And she'll end up with an overjet, right?
Exactly right.
Yeah, that's the only problem.
Yeah,
some people, I tell you now, some patients notice that.
Yeah,
they actually notice an overjet. For funny enough, they think, why my teeth not come together?
Yeah,
I don't know if you've ever met that, but some of the patients think their teeth should be edge to edge.
Yeah, but firstly, a couple of points there. Take out the lower right lateral, not the central. Okay, because that's the one where the root is so far back. So I'd take out the lower right lateral here. Okay, if I was taking out a tooth in this.
Okay.
By the time you rotate that canine, you've basically already taken up half the space. Okay. Now, I'm assuming there is some type of Bolton discrepancy as well.
I'll do the analysis. Yeah, I will.
Yep.
Yeah.
But then what you need to do, if there is, and you've taken out a lower incisor, you redo your Bolton analysis. Okay, based on, hey, I've now got your 6 upper anteriors and I've got 5 lower anteriors. So redo your Bolton analysis with having that 4-2 removed.
Yeah.
And then you might need to do a little bit of IPR on the uppers to allow you to get a overjet.
To reduce it. Yeah.
Yeah. So by doing your Bolton analysis or even a diagnostic setup, okay, then you're going to see exactly how much overjet you will be left with before you start, and you can determine how much IPR you need to do. So there's no reason why you should be left with overjet if you manage this properly from the diagnostic point of view, even with the lower incisor extraction, if you've already got a Bolton discrepancy. So, for example, let's say you've got 3 millimeters of excess or in the lower arch, just for argument. Okay, you take out your lower incisor. You have 2 millimeters of deficiency, and you just reduce the upper tooth structure.
But what if the excess is not in the lower arch? What if it's in the upper? Would you still?
I'm going to be surprised.
Yeah, but I'm just saying, let's say a case it was, would you still? You wouldn't take out lower central then, or lower lateral, would you? Then?
Probably not.
Yeah. Okay.
Yeah, but I would have to. You'd have to look at each case on its individual merit.
Would you? Okay, so my diagnosis and treatment plan wasn't incorrect, but I was settling for 5s. Would you ever consider 4s? By the way.
Yeah. Well, yeah. Why not?
Okay.
Okay. Once again, it's a question of managing your anchorage.
Yeah.
Okay. And it comes down to, in your problem list, what do you want to achieve? If you want more retraction of those teeth, and that's a decision that whenever you do your problem list and your diagnosis, it then becomes, at that point, a discussion with the parents as to what do they want. Okay.
Yeah.
So if they want a bit more retraction, because there's a lot of people out there today, especially in Australia, the Asians especially, who actually want more of a Caucasian profile.
Yeah.
Okay, so it really comes down to not putting our value judgment always onto the patient.
Yeah.
And just saying, hey, here are the options. Okay, but we are only when we get so worked up over taking out 4s or 5s or whatever it be, we're probably talking 1.5 millimeters of difference at the end of the day. Okay, yeah, well, we get so worked up over it from a diagnostic point of view, and and so we can feel really good about ourselves, okay? But it's really not. It's really probably not a big deal of difference, at the clinical result. I've done a lot of 4 premolar extraction cases on Asians Bimax protrusions, and you retract them, but they're still Bimax protrusive.
They're still look full, yeah.
Yeah, and a lot comes down to the thickness of their lips. If they've got thin lips, you'll see far more in the way of retraction. So, taking out 4s, no, that wouldn't be wrong if your goal is to give a bit more retraction.
Yeah.
Okay.
Whenever I ask the other orthodontists what teeth to take out on the upper, if you're taking out 5, they go, it makes no difference because you're going to end up with class 1 canine. So determine what you want to take out on the lower arch, and then the upper arch makes no difference because you're going to end up class 1.
So say that again.
Okay, so whenever I would ask for advice, what teeth to take out, if I just already decided what I want to take out in the lower arch, they would tell me that it makes no difference what I take out in the upper because I've still got to end up with class 1 canine, whether I take out 4s or 5s.
Absolutely, correct.
So determine what you want to take out in the lower arch. It makes no difference in the upper. That's what they say.
Correct, except to the point it makes a big difference in how you manage the anchorage to achieve that. That's where the difference lies.
Mm.
Okay, so so they're right. If you're going to take out a 4, you're going to take out a 5. But now what you're going to need to do is to move this molar all the way forwards.
Yeah.
Okay, so it's the anchorage and the mechanics that will make it easier for you.
Yeah.
Okay, so what they're saying is a bit of with all due respect, is an oxymoron statement. Okay. Okay. So it doesn't. Okay.
Yeah. Yeah.
So,
no, I get it.
Yeah. I mean, you could argue it doesn't. You don't even have to extract in the upper arch. Then just distalize the entire upper arch or whatever it be, because you're still going to end up with a class 1 canine. That's what your goal is.
Yeah.
Okay. But the point is, what's going to make your mechanics much easier, because what you want is what we call a moderate anchorage situation, where you have the same amount of movement of the posteriors coming forwards as the anteriors coming back. If you can keep that, that's your mechanics. Whatever you do in orthodontics, basically that is your basic mechanics. That's what you end up getting, is that reciprocal effect. Now we can enhance our anchorage with elastics. We can enhance our anchorage with palatal bars, Nance splines, whatever we want to do, but it just complicates it and makes it really a lot more difficult.
Yeah. Can we just quickly go over the consistent versus inconsistent forces, just with regards to?
Yep, absolutely. Okay, so let's look at the lower arch just for 1 second. Okay, so here we are. So we're going to go ahead. So whatever approach you're going to do, you're going to put your brackets on the lower arch.
Yeah. No, those canines are rotated.
Yep. So let's look at the most significantly displaced tooth.
Canine.
The canines. So what will be the side effect of that?
Crossbar. Oh, you'll create a narrow arch.
You'll narrow that arch. Do you want to narrow the arch? Now, if you're doing extractions, it'll probably be a good thing.
Okay.
Right. Okay. So you're in no rush then. If you're extracting, if you're doing this non-extraction, okay, let's say you just wanted to do it non-extraction, you would need to expand that arch form, correct?
Yeah.
So then now you've got an inconsistent force system going on, because you're actually getting constriction when you actually want expansion of that arch form.
Okay. Oh, gotcha. Yeah. Okay.
But if you're extracting teeth, you are going to have to narrow that arch form a bit. So that's going to end. So you're going to look like a genius. You put your brackets on, and you wouldn't be. You just let your brackets do the work there in the rotation, because that wire is going to sit there whilst it's sitting there for, as that tooth slowly rotates. It will slowly rotate. Okay, but whilst that wire is sitting in lingually to the to the posterior teeth, it's going to cause a constriction of those posterior teeth.
Mm-hmm.
If you were going to do this non-extraction, okay, then that's terrible. So what you would want to be doing is rotating that tooth as quickly as possible.
Yeah. Where would you put the button? Because if you put on the lingual of the 3 to the 6, the 6 is already rotated a bit, so you're going to make it more.
So what you would do
I
is
could put on the premolar, that first premolar, maybe.
you could do, but you probably want to rotate the molar mesial to the lingual. So you just run your power chain from 6 through one of these contact points.
Oh yeah, that makes sense. Yeah.
Around to the canine.
Easy. Oh, can I just say, you know that canine that got stuck that I showed you with that girl? It's coming down, which is nice.
Oh, good. Good.
I know. I'm so glad. It's not ankylosed, so that's good.
Okay, so now on your upper arch, okay, on your upper arch, you really don't have too much in the way, of inconsistent force system except for this high canine. Okay, you've got a little bit of a deep overbite, and your question here is, do you want to intrude your upper arch? Probably not.
Probably not.
Okay, so that's the part that you need to get this canine down as quickly as possible. Okay, or you bypass the canine, open the space. Okay?
That's what I would do. Yeah.
Bypass canine, open the space, and once you've got enough room, bring it down very quickly, maybe with some elastics.
Yeah, that's what I would do. Yeah, and then lock it in. Yeah.
Yeah, and then you've got no issues from a biomechanical point of view.
So it's not too difficult a case, is it?
No, it's not. It's actually pretty straightforward.
Yeah.
The question is,
to extract or not to extract?
Which way do you want to go?
Yeah.
Personally, if it was me,
what's her lower anterior tissues? What do they look like? Can I just have a quick? Are they thick?
They're pretty good.
Yeah, that's right.
That's a pretty thick gingival type.
Yeah, it's not too bad. Yeah. What would you do? Can I ask?
Yeah, to be honest, the only
other good thing is if you did non-extraction, if you look at the lower arches, actually those premolars are lingually inclined, which means that when you upright them, you gain more arch space. So that's a good thing. Yeah,
but it won't be a great deal.
Won't it? Oh.
Yeah, I mean, look, it is a positive, but you got to also remember that in a normal occlusion, they should have some lingual inclination.
Oh, okay.
Because you need that curve of Wilson. From a prosthetic, restorative point of view, there should be some lingual inclination. They shouldn't be sitting totally upright.
Yeah.
Yeah. For example, when you have your bracket prescription, right? Okay. Every posterior tooth has more, as you proceed posteriorly, has more buccal root torque.
Yeah.
So you actually want some lingual inclination as you're going posteriorly. So it's not that bad. I mean, you'll get some uprighting as well, but you've got to also look at the upper arch here as well, because if I'm going to upright these lowers, I'm going to have to upright these uppers. The uppers don't look too bad.
Sorry, what would you do then? Just out of curiosity.
What would I do? Honestly, I'd take out the lower.
Central. Oh God. Okay.
Lower lateral.
I mean lower lateral. Yeah. Okay. But you have to do a diagnostic setup first.
Absolutely. Yeah. I would get a diagnostic setup first, and I'm going to try and keep this case as easy as possible. But the first thing I'm going to go and say to the patient is, do you want your teeth brought back at all?
They're probably not going to know.
They're probably not.
They're going to, I don't know, I just don't want this canine sticking out.
yeah, and that's fine. But that way you've covered yourself, okay? Because you've gone through the discussion, okay? We could take out 4 teeth here. That would be the textbook. This is how I would explain it to them.
Yeah.
The textbook way to proceed is to take out 4 teeth. Okay, that's the textbook way. We're going to have 2 years of braces, and blah blah blah. The other option is our main issue is is the lower front teeth and the lower centre line. And are you worried about the lower centre line? They go, no, that's fine. Okay, Well, still the main problem is that lower front tooth here. I could take out one lower front tooth. I can get that other eye tooth in. You might end up with a little bit of overjet, but I could do some things to improve that. But we could get you done in 15 months.
Mm.
Because sometimes you've got to ask yourself, the risk versus the reward situation. And I'm not saying, and don't get me wrong, I'm not saying taking out teeth is incorrect, okay, at all.
Yeah.
Premolars. In fact, that is the textbook option to go.
Yeah.
But I think this is a discussion with the parents. Provided you do more good than harm, then I don't have a problem with the lower incisor extraction at all. Because one of your issues is going to be, even down the track, bonded retainers or not, is going to be the retention of that lower right lateral. Because
you've got it. It's because of the weird position of the root, isn't it?
Yeah, you're going to need to do a lot of work to get that root in the right position.
Yeah, makes sense.
Okay, so I'm just once again mitigating one of the long-term risk factors.
Okay.
Okay.
All right. Thank you so much.
That's a pleasure, Naomi. Look, it's interesting. It's not a difficult case at all.
Are those photos acceptable?
Yeah, those photos are very good. I just want them.
I know, I've got to get more on it. I know.
Yeah, just more straight on. Your centre photo is perfect. Okay,
yeah.
That's really good. Your occlusal photos are actually very good too.
I tried to get the 7s. It's so hard sometimes. They just don't open big enough.
Yeah, absolutely. Also, try to get the tongue out of the way. But
you ask them to move the tongue and it comes out more.
Oh, absolutely. No, the photos are very good. Your extra-oral photos are very good. Okay, so that's all good.
Okay.
You're all good. And your Ceph at OPG is very good indeed.
Yeah, I'm paying more attention now.
Yeah. So your diagnostic records are actually very good. Yeah, and that's a really nice picture. I love it. I wish we could show the eyes because that gives you a much better idea.
We can amongst us, can't we?
Sorry?
Aren't you allowed to show it amongst us if it's a study group?
No, because I record the session.
Oh, sorry. Okay.
Yeah, and that's the only reason. So we send recordings out.
Yeah. Okay.
Okay, so that's why. Otherwise, but I have to even hide the photos when I do my own lecture material. Okay.
Yeah. No, I understand that.
Yeah, it's just privacy. Because somebody knows them and whatever it be. That type of thing. So no, that's all really good.
Does Ari do diagnostic setup?
Absolutely.
Yeah. Okay.
And he can do it.
He makes my herps. He's very good, Ari.
Yeah. He can do it digitally for you.
Oh, okay.
Okay, which I think is probably the best way to do it now.
Yeah.
But when you get Ari to do it, what you need to do is, because you can do it, you can make a pretty picture out of any diagnostic setup. So tell him just to do it. If you're going to do a lower incisor extraction, leave the all the posterior teeth in place. Just do basically a upper and lower 3 to 3 diagnostic setup.
Okay, just 3 to 3.
And that way you can determine how much IPR you need to do. Okay. So just look, and you may end up with a little space distal to your canine in the diagnostic setup. I'd rather that, because that'll tell you how much anchorage loss you can afford in that lower arch.
Mm-hmm.
So leave all of these posterior teeth in place and just do the 3 to 3. Okay, because he could go ahead and expand arches, do all that type of stuff, but then all you've got is a pretty picture.
Yeah.
Okay.
Yeah.
But it'd be interesting to do a bolt analysis, both, and ask Ari whether his software can do a bolt. When he measures the teeth, can he do an automatic bolt analysis? Okay, with the lower incisor present, and what it would be if you take out that lower incisor.
Okay.
So we can get an idea of how much IPR we might need to do in the upper arch.
Yeah. Yeah. I'm just concerned that the Bolton's analysis is not going to be in my favour, because I don't see that to me, the upper set, the laterals look wide.
It may not be.
Being in my favour, that's all. They don't look narrow to me, the upper laterals. Didn't you say that you look at the laterals and compare them in size?
Oh, that is your quick guide. Okay.
Yeah, well, as a guide, yeah.
But to me, it looks like she's got very wide lower anterior teeth.
You really?
Yeah,
They look normal.
Maybe, but
They look normal. I don't know. All right, maybe whatever.
I mean, do it and then we can see.
Okay.
That's and I'm happy to have a chat to you after you get the bolt analysis back.
All right.
Okay, guys.
Thanks so much, Jeff. You're great.
That's a pleasure.
2 weeks, isn't it? 2 weeks. 3 weeks. It's 2 weeks in Melbourne, isn't it?
No, God, I'm just looking at my calendar now. August the 1st.
So.
Yeah, is that 2 weeks?
I've crossed it off on my calendar.
Yeah, August Thursday, Friday, and then Saturday morning.
End of this month, so it's about 2 weeks. All right.
Yep. Okay, fantastic. Well, we'll see you next Wednesday. We're probably going to have a short session next Wednesday because I'm doing Module 7 in Brisbane. So Robin and I will be flying out early Wednesday. Okay, guys, we shall see you next week.
Thanks, Rob. Thanks a lot.
Okay. Thanks for that. See you later.
Bye. Thanks.
Bye. Manita, you are totally correct. Yes, you could place a power chain from the buckler 6 to the lingual canine. That's exactly what we suggested. Well done, Manita.